And next speaker, we have Dr. Shaik Manzoor Eilahi, who's a consultant, Dr. Mehta's Hospital, Chennai, and he would be presenting about communication and errors in ED, emergency department.
Yes, hi, very good evening, everyone. So I'd be engaging you for the next 15 to 20 minutes on this pleasant Saturday evening about communication errors in the emergency department. So today I'm here representing Dr. Mehta's Hospital, Chennai. We are a 90-plus-year-old organization, healthcare organization in Chennai. So let's dive right in. So before I go into this topic, I'd just like to set some context why. Right? Why is this communication in emergency so important? Communication in the entire healthcare spectrum is very important, but why in emergency? Because there are enough research studies to substantiate that poor communications are the major cause for patient harm. Among all the other avenues of patient harm, poor communication has been highlighted as one of the major causes by none other than the Joint Commission in the 2014 paper. To top it up, why not? Right? So there have been research studies which have shown implications of poor communication as the resulting in dissatisfaction of the customers to the care provided to them, subsequent complaints by the customers, and decisions to pursue litigations, which healthcare organization wouldn't want to have any of these three in their system, right? And back to basics, right? So what is patient safety and why are we here today? So to give a bit of a context about background about this slide, about yesterday, my cardiologist was saying you are speaking something in Kaho about patient safety. What is this patient safety that you guys do? So if there are any cardiologists out there and who don't know what we are doing here, so we are here for patient safety, which is the reduction of risk from unnecessary harm associated within the healthcare to a bare minimum. So that's from the WHO. And this is who we are, right? This is about the emergency medicine department, the ED. So we are probably the only department who can cause patient harm even before they have come into our system, right? For example, imagine somebody makes a call and EMS call and they want an ambulance. They want help to be sent at the site, at the, our pre-hospital care. And we get it all wrong. We get the location wrong, or we get the address wrong, or we get the resources wrong, harm right there. So as you can see, it's a very busy area, right? We don't work in silos. So there is the pre-hospital component, then there is the transport component, then we interact with everybody, human resources, operations, HDUs, inpatient wards, clinical staff, non-clinical staff. So there is this terminology in Lean Six Sigma, which says defects per million opportunities. So trust us, we have a million opportunities to go wrong. So it is very important for us to have really good communication set and prevent errors due to communication. So these are the ED communication challenges. For us, there is unpredictability. We don't know how many patients will come when and what is going to be the profile of these patients. There is unfamiliarity. We have never seen these patients before, right? And when this patient comes, they have no medical records either, most or more often than not, even if they are coming to the same hospital. So it adds a lot of challenges to us, right? So top it off with the complex, high stress, dynamic work environment of the ED. This creates a communicative complexity. So yes, there are challenges in emergency department, which are probably a little higher than other healthcare settings, right? So there is some research done to substantiate that, not just Manzoor, but research says that in the emergency department, there are challenges and we have to rely very heavily on effective communication in a very short duration to make the patient understand what is the problem and get their buy-in to go ahead with the proposed care. So this is the ED flow. So this is a high level diagram. This is how any ED would, majority of the EDs would work. You have your supplier, input, process, output, and your customers. So patients come to the ED, they are triaged, they are registered, and subsequent parts take place and they are discharged, right? I would like to just highlight an incident which happened in our hospital in patient registration, right? Our lab called up and said, Sundar Prakash has a critical alert value. And we retorted back to the lab saying there is no Sundar Prakash. And they said, no, you have sent the sample, you have put the labeling, and there is a Sundar Prakash, and it has a critical alert, sort it out. So we are searching for the Sundar Prakash, and then we find out in bed number 4, there is one Arul Das. So he is actually the Sundar Prakash. Immediately self-doubt. We blame the nurse, we blame the coordinator. You got the wrong name wrong. This is the identification error. This is a sentinel event. This is a red event. Then ultimately it turns out that person actually said his name was Arul Das, which he later changed it to Sundar Prakash for numerology sake. So our customers can really surprise us, and errors can happen from unknown tangents. Okay. So in the ED, furthermore, to add to the ED context, which I already have, I guess, so we have a lot of, we work 24/7. There is no time off. Our operation hours are 24/7, and we work in a shift-based culture. And the environment, ED environment, is predominantly noisy. And though we try our best, sometimes we have challenges to provide both privacy and comfort to the patients. And this is the map of a patient, a normal patient who presented to emergency. And by the time the patient got discharged and went home. So see the innumerable amount of communications or interactions the patient has had, like a complex spider web, just to have a simple consultation and go back home. This is not even a complex case to add, right? So I think I've successfully added a bit of context about why it is, who we are and how the ED is, and why it is difficult for us to have some of these communication challenges. So before we move on, let's talk about some of the risks where the knowledge or information can get lost or get lost during the transfer phase, right? So one is the communication load. The ED physicians, doctors, they have a lot of cognitive load. They have to remember a lot of important information about various patients. So more the patients, more the crowding, more the challenge. And then on the opposite horizon, there is the patient. There is a lot of communicative overload on the patient. First, the nurse, the triage person will ask you what is wrong with you. Then the nurse, during the nursing initial assessment, will ask what's wrong with you. And then the doctor will come and ask you what is wrong with you. ED doctor will come and ask you what is wrong with you. And if the hierarchy is different, then the senior ED doctor will come and ask you what's wrong with you. And then finally the consultant will come and ask what's wrong with you. So there is a lot of overload on the patient, and they get very, very angry and agitated, answering the same thing over and over and over again. And their quality of responses deteriorate, or they save their best response for the last, knowing that I will tell all the information to the consultant. And once the consultant comes and we don't have information which he has, he will give us a dirty look, right? So it can happen. There are communication challenges with multidisciplinary care. So we discuss, we communicate with all the specialties, neurology, nephrology, whichever ology you want, right? So it happens. So there are a lot of challenges. I'll take a leaf out of my own book. So probably when I was much at my early career, I called my neurosurgeon and I said, sir, I have a 44-year-old male patient who was apparently normal, and 2 days back he said, buddy, I'm in the middle of something, give it to me short and sweet. I said, sir, there's a 44-year-old male patient, probably SDH, probably 10 hours old. There is a midline shift, mass effect, needs surgery. He said, perfect, wonderful, I'll take care. So a week or two later, there was a MI patient. I called the cardiologist and I gave the similar thing. Sir, there is inferior wall MI, there is needs PTCA, something. The cardiologist said, very good, do one thing. You admit the patient under yourself, since now I feel you have a diploma, DM in cardiology, and you treat him himself. So he was not happy with the same type of communication which I used with the neurosurgeon. So one size does not fit all. So these are the kind, I just want to give a snippet of how it is difficult to challenge with the different spectrum of specialties and people. So we have to know how to get the message through effectively and efficiently with each person in a tailored manner. And then the patient is an outsider, right? So when you're speaking in front of the patient, in the patient areas, we have to be very careful. You cannot suddenly say it's a C3P4 package patient, move him to the ward. So patient doesn't know what is this C3P4. They get anxious. So we have to avoid using jargons and different understanding of time for the patients and the healthcare workers who are working in the emergency department, right? So we are there. We probably just started our shift. So if we, for example, say, I'll be right back with you. For me, it may mean 30 minutes. For him, it may mean a minute or two. So we have to be very clear. We have to say, sir, we have done so and so with you. We are awaiting so and so. I'll probably come and reassess you in an hour, in 30 minutes, in 15 minutes. So we have to leave nothing to chance. All right. So for the next 3 minutes, I will try to take you virtually into our ED world and show how some of these communication errors in the ED can cause patient harm. So while I do that, I need to take an urgent call. So I will delegate it to my digital alter ego.
Hi, I'm Dr. Manzoor, older and hopefully wiser AI version of Dr. Manzoor. Let's look into a few examples. We're talking about situations where seconds count and a single missed word or misunderstood instruction can be the difference between life and death. Imagine this. A patient comes into the ER with severe abdominal pain. They've been seen by the night shift, had some initial tests done, and are waiting for more results. Now, shift changes here, and the responsibility for this patient is being passed from the night team to the day team.
A lot can go wrong in a handoff. Maybe the outgoing doctor forgets a crucial detail, or there's a misunderstanding about the plan of care.
A key lab result might get buried in the electronic medical record. That could be a life-threatening oversight.
The ER is loud. Machines beep, alarms blare, and people are talking all at once. It's a recipe for disaster, especially when it comes to verbal orders. Picture this. You're in a trauma situation. Every second counts, and the attending physician barks out, "Give 2 milligrams of morphine."
But because of the chaos, the nurse hears, "Give 20 milligrams of morphine."
In this case, the patient might receive too much and can result in severe respiratory depression or even death.
We've all heard the saying, if it wasn't documented, it didn't happen. And nowhere is this truer than in the emergency room.
Let's say a patient comes in with a severe allergic reaction to diclofenac. It's vital that this information is clearly and prominently documented in their chart. Later, another healthcare provider, unaware of the allergy, might accidentally administer the same medication. The consequences could be fatal.
The ER can be a pressure cooker of emotions. When you add life or death situations to the mix, communication can completely break down, even among experienced professionals.
Imagine a patient going into cardiac arrest. In those first few minutes, it's all hands on deck. But what if roles and responsibilities aren't clearly defined? What if there's confusion about who's doing what? Vital seconds are wasted, and the patient's chances of survival decrease with every passing moment. In the heat of the moment, something is going wrong, but junior staff hesitate to speak up, especially if they're new to the team or feel intimidated by senior staff.
This authority gradient can be a real barrier to effective communication. In the ER, we rely heavily on lab and imaging results to guide our decision-making.
Imagine a patient arrives at the ER with severe chest pain. An ECG shows signs of a heart attack. The patient is sent for a cardiac catheterization.
The lab calls in and says potassium level is 9. You mishear it as potassium level is fine.
Result, the patient may go into cardiac arrest.
It's time for me, Mandroid, to sign off and give a handoff to my real-life version, Dr. Manzoor, who I firmly believe by now is done with his fake phone call and returned to my digital world.
All right, so I am back. I hope you liked Mandroid, my digital alter ego. So here is the vicious cycle, communication and ED errors, and I hope I know certainly that few of you can add even more to this. So as you can see, we are prone for errors. It can happen anywhere, and the consequences can be sometimes even fatal. So it's very important to have best practices and prevent these errors from happening. So how do we do that? So how do we do that? First, it is my take of communication. Communication is not just speaking, it is written, verbal, and non-verbal. So we have to know in which situation we have to switch to. We have to opt for written form of communication, in which situation we should switch to verbal form of communication, and in which situation we should use non-verbal communication, which can even sometimes mean just the body language of this person. So there are various, websites and literature for communication, but the one I have chosen, so this is the example of written form of communication. So this is our
Doctor, we have your last 2 minutes, please.
yeah, I'll take care. So this is our core of our ED, helps us prevent a lot of communication errors. And then our handoff tool, so we ensure that we have no handoff errors. So the tool which I was talking about is Team Steps, which is by AHRQ, a very renowned agency. As you can see, they have listed out all the various barriers for effective communication, tools and strategies, and the most important outcome that we are interested in is the safe and highly reliable patient-centered care. That's what we want. So let us very briefly touch upon Team Steps. So as you can see, steps is status of the patient, status of team members, the environment, what we can control, what we cannot control, and the progress towards the goal, that is safe and effective patient care. So there is closed loop communication where you close the loop. For example, you can say give 10 milligrams of midazolam. The receiver says, okay, 10 milligrams of midazolam loaded, 10 milligrams of midazolam given. So that is the example of a closed loop communication. S bar, we have already showed you. Check back, very, very important and useful tool, especially when you are on telecommunication, when you are speaking with the consultants. And iPass, a fantastic tool when for across department transitions, especially for us when we transfer the patient from the ED to the ICU, helps us prevent a lot of communication errors. And then my most favorite CUS, that is at any given point of time, any hierarchy, it may be the department head, it may be the consultant, but if the team member feels that there is a risk for the patient safety, they can just say, stop, this is a safety issue, you cannot go ahead. And of course, there are always interdepartmental issues and misunderstandings. So desk is again a wonderful tool to have a good communication among yourself. So why I chose Team Steps? With collaboration with SEMI, we have done some quality research and validated Team Steps as a tool within Mehta Hospital over a 6-month period with 25 people as participants, and we found it to be have significantly improved the performance. So in conclusion, it needs a system fix, process fix, and most importantly, a culture fix. There is no one size fits all solution for anybody. My organization is unique to yours. We need to break silos. We need to assess, train, reassess, and retrain. It is a continuous process. It has to keep going on. Only then we will have sustained good results. All right. Thank you, everyone. Thank you, Semi. Thank you, Saravana sir. And thank you, Srinath sir. Thank you, Kaho, for the opportunity.
Thank you for that wonderful deliberation, Dr. Eilahi. And thank you for bringing your AI Manzoor also into the scene. Thank you so much.